الموضوع هذا شوية مختلف حقيقة عن الGI، لكن الموضوعين التالية يعني مرتبطين ببعض. It's about fever and infection. التوبيك الأول اللي هو hospital acquired infection, and this is a real headache for anyone working in hospital, خصوصا من infectious disease for infectious control, as well as us as a medical profession, because there is a clear rise on the organism resisting antibiotic, and the choices of antibiotic are basically become less and less. So those are the objectives of today's lecture. So what is دائما السؤال وش معنى what is hospital acquired infection? Hospital acquired infection as simple as انه you contracted in the hospital. Okay, يعني a disease you contracted, you got it from the hospital. Okay, we tend to think about a hospital acquired infection as يعني a resistance bugs, which is still hold true, but any infection you acquire it in the hospital, it's considered as nosocomial or hospital acquired. حتى لو كان, let's say, COVID. If you acquired COVID while you are in hospital, while you are working in hospital, this is considered as hospital acquired infection. But just to give you a background about the impact of hospital acquired infection and why it's a nightmare for any administration working in hospital. Okay, طبعا we don't have a lot of data from Saudi Arabia. The US, given that it's insurance driven, we have a lot and tons of data. So we have up to 2 million hospital acquired infection in the US, 2 million, okay? And up to 100,000 deaths annually, okay? What surprisingly is half of them are preventable. And we're gonna talk about how to prevent those cases and cost not millions, only billions, okay? And then they are trying to see, when it comes to the prevention or protection, how much patient receiving the standard of care protection, only 55%, okay? So Medicare, which is خلينا نقول the US government insurance, هذا Medicare, made a very bold decision in 2008. قالوا للمستشفيات, we no longer cover the costs of a certain preventable diseases. So اللي يصير عنده المستشفى catheter associated UTI, we're not going to actually pay for the cost. If you have someone with vascular catheter associated infection, we're not going to pay for that. If you have someone develop pressure ulcers in hospital, we're not going to pay for that. So this gave the incentive للمستشفيات انهم to try to prevent those infections, because they know if this happens, they will pay it out of pocket. Okay, and this is one of the ways to improve a healthcare policy. This is just to summarize what we just mentioned, and this is just an example of the common costly hospital-acquired infection, central line associated bloodstream infection, ventilation or ventilator-associated pneumonia, surgical site infection, C. diff. They are costing billions and billions, okay? So what are the most common sites of nosocomial infection? You see clearly the winner here is UTIs, urinary tract infection, okay? Second to it will come the surgical infection, and then others, but the third one is lower respiratory tract infection, and this is including, for example, ventilation-associated pneumonia. Okay. Okay. What may make people predisposed to a hospital-acquired pneumonia? Well, the resistance organism develop or let's say widespread by the inappropriate use of antibiotic, overcrowding in the hospital, so that's making people exchanging those organisms easier. In general, the poor environments, we're talking about the ventilation, if there is a poor ventilation, the housekeeping, the other stuff in the hospital, as well as those patients in hospital, somehow they are more vulnerable, whether they have low immunity, they have an ongoing infection, they have other factors make them more vulnerable to be infected. Okay, so this is 101 microbiology to explain how the resistance bacteria survive, okay? So if you have even a normal flora, for example, and one of the bacteria get mutants, okay? And then you give inappropriate antibiotic, kills them all except one, this will become the new normal flora. It's an organism resistance to the antibiotic already being used. Okay, so who are the usual suspects for hospital-acquired pneumonia? Well, you're gonna hear this a lot. MRSA, methicillin-resistant Staph aureus. Okay, so Staph aureus, long time ago, they were sensitive to as simple as penicillin. Okay, but with time, they become more resistant to those antibiotics. And now there is this a group of Staph aureus, they are resistant to methicillin, which is a kind of beta-lactam, and some of them, they are even resistant to vancomycin. And the resisting story continues, okay? This is just to explain that MRSA, they are actually exchanging this genes, okay? Okay, so I thought it's very nice to see the nature and the timeline of the resistance of Staph aureus. Staph aureus was discovered in 1880, long time ago, okay? And in 1940, the antibiotics started to be used. This is during the World War II. And they were treating Staph aureus with penicillin, basically, okay? In 1944, that was the first time someone reported a case of penicillin-resistant Staph aureus, MRSA, okay? And then, sorry, the first was to penicillin in 1944, okay? And then in 1959, methicillin was used to treat penicillin-resistant Staph aureus, so it's become available in the market. And then the first case of MRSA was reported in 1961, okay? And then it's become infecting human in 1968. And now, first documented vancomycin-resistant Staph aureus in 2002. And the story continues. Okay, so we have a case by a 51-year-old woman with a history of heart failure, ejection fraction of 22%, and atrial fibrillation, comes to the emergency with increasing shortness of breath and lower limb edema. Medication, she's not taking any because financial issue, but she was supposed to be in warfarin, lisinopril, Lasix, spironolactone, bitabirolol, amiodarone, and digoxin. Her physical examination basically suggesting of volume overload with tachycardia, hypotension, saturation of 90%. She had bilateral crackles and irregular heart rates with S3 and bilateral edema. She had leukocytosis, and her EBG basically showed hypoxia. Oxygen is 77. ECG showed atrial fibrillation, and the chest X-ray showed pulmonary edema. So she was admitted as a case of heart failure, treated with furosemide. And day 5 of hospitalization, she became hypotensive, tachycardic, hypoxic, and her chest X-ray revealed a new lower lung infiltrates. Okay, so how would you manage this patient? So what do you think the diagnosis is, and how would you manage them? So what's the diagnosis first? That's fair, yeah, Martez. But what the diagnosis first? Center, hospital-acquired pneumonia. Okay, and maybe MRSA. That's right, because she's in hospital. So let me explain something before. Uh, Hospital-acquired pneumonia, we said simply, are the disease contracted in hospital. Okay, but don't forget something that you may actually contract, you may actually start to develop something in hospital, but the symptoms not going to be appearing except after discharge. So, for example, if this patient went home and after 1 day she developed the same symptoms, still would be considered as hospital acquired. Okay, because we think that the organism got in her lungs before discharge. Is this clear, guys? Right. So this is uh, most likely hospital-acquired pneumonia, can be MRSA. So we'll do ABC, antibiotic of choice. Definitely we should cover MRSA. So we'll give something like tazocin and vancomycin. So vanco to cover MRSA, tazocin to cover a gram-negative as well as a gram-positive cocci. Okay. So vancomycin still is the gold standard medication for MRSA. Regarding the clindamycin, so clindamycin is good for those people having community MRSA. So the community MRSA, usually it's sensitive to clindamycin, so it would be a reasonable choice. Linezolid is a reasonable choice, but we don't usually use it for pneumonia because we're not quite sure if it is effective. Daptomycin, we use it for soft tissue tract infection, like cellulitis in someone we suspect MRSA, as well as tigecycline. Okay, so those are the antibiotic we can use for MRSA, but vancomycin is the gold standard. Okay, a second group of resisting bugs is what we call ESPL. Okay, so extended spectrum beta lactamase organism. Okay, examples for those: Klebsiella pneumonia, so can be ESPL. E. coli can be ESPL. That doesn't mean all E. coli or all Klebsiella are ESPL, but there is a strain from them. They are ESPL. Proteus, Enteropactor, non-typhoid Salmonella. So they all actually gram-negative bacilli. Okay, and you see it here, gram-negative bacilli. Okay, so let's take a second case. 62-year-old admitted with a hip fracture requiring hip replacements. Her past medical history only significant for diabetes, on metformin. Post-op day 4, she started to have fever, bladder and right flank tenderness. She has indwelling catheter. Urine analysis showed leukocytosis plus leukes and plus nitrate. How would you manage this patient? So what's the most likely diagnosis first? So what's the most likely diagnosis in this case? But then I will go back, Abdulaziz, and explain ESBL again. This is most likely catheter-associated UTI, okay? Catheter-associated UTI. Regarding your question, Abdulaziz, what is ESBL? ESBL meaning extended spectrum beta-lactamase organism. So it's B, not P. Huh? So that's meaning those organisms are having a wide range of resistance toward beta-lactam antibiotic. And the beta-lactam antibiotic basically containing penicillin or penicillin family, as well as cephalosporin. Okay, so they have a wide range of resistance. Okay, is this clear, Abdulaziz? But how to manage this? Well, of course, as always, ABC, ABC, ABC. We should send urine as well as blood for culture and sensitivity. And then we should start broad spectrum antibiotic covering for ESBL, given that she has the disease while in hospital. And then don't forget to remove the Foley if there is no need for it. Okay? You have to remove the source of the infection. Okay? So what are the medication can be used for ESBL organism? Well, carbapenem, like meropenem, imipenem, ertapenem, those can be used. Also, rarely been used in practice, honestly, kefamycins, fosfamycins can be used for lower urinary tract infection, as well as nitrofurantoin. And we can use what we call it beta-lactamase inhibitor. That's on الأورجانيزم ذولي they produce beta-lactamase. Okay? فيه group of antibiotic we call them beta-lactamase inhibitor. They inhibit this beta-lactamase enzymes like clavonic acid or tizobactam اللي هو levetiracetam. So they also can be used non-beta-lactamases antibiotic as well as colistin. So we have a long list. In practice, probably carbapenems are the one commonly used for ESBL. Okay, the third group we're going to talk about is what we call it enterococci. Okay, so they are a gram-positive cocci. Okay, diplococci. Usually lives almost everywhere, soil, food, water, just name it. In human, they usually reside in the gastrointestinal and the female genital area. So they live there. And when they live there, that's meaning they sometimes cause trouble over there. So they will cause UTI, they will cause GI infection. Okay? So, a group of those enterococci, which is the enterococci faecium, they started to develop this enzymes, which is inhibit the cell wall, okay? And this basically started to get resistant to vancomycin. So all these bacteria, basically, what they do, with time, they develop these mutation, okay? And mutation, they give them the ability to resist a certain antibiotic, or they started to have a new gene, and this gene is making them produce, for example, a new enzymes, making them resistant to the antibiotic, okay? So the percentage of VRE is basically strikingly rising over time, okay? you can see this up to 25% now of the VRE rising, okay? So this is very concerning, and you don't know how long this is going to continue for. So we have two types of enterococcus, or vancomycin resisting enterococci. Okay, we have the fascium. Okay, so fascium, it's a rare infection, but it is the emerging cause of VRE. Okay, so it's actually in the rise comparing to fecalis. So fecalis is a common cause for infection, but rarely having VRE. Okay, so rarely having VRE. So fecalis is a common infection, but rarely are VRE, comparing to fascium, which is a rare infection, but most of it is actually VRE, okay, and colonizing people in hospital. Okay, so let's take this third case, okay? So 39-year-old admitted during labor. Her postpartum course was complicated by postpartum hemorrhage, requiring massive transfusion. She was intubated, placed in inotrobes, and shifted to the ICU. During her ICU stay, day 7, she started to have fever reaching 39. A full septic workup was sent, including chest X-ray, blood and urine culture, as well as sputum culture. Her central line grew gram-positive cocci in pairs. So how would you manage this patient after securing the ABC? So what do you think the most likely culprit, the most likely cause of this central line infection and now growing gram-positive cocci? It's a kind of just continuation of what we've been talking about. So this can be a VRE indeed, can be enterococci, and when it's enterococci, it always can be a VRE. We always assume the worst. And how would you proceed managing this case? Well, the option we have in VRE are as of the following: linezolid, daptomycin, tigecycline, and maybe nitrofurantoin, but nitrofurantoin usually for the simple infection, okay? So remember, linezolid, daptomycin, tigecycline are for VRE, as well as we can use them for MRSA, okay? Okay, she will need to have an echo to rule out infective endocarditis. So I'm gonna ask a question. Oops. So we said that fecalis is common infection, but rarely VRE. Fascium, it's a rare infection, but common VRE. So here my question, which one among them do you think can and more commonly cause endocarditis? Good guess, good guess. It's actually still fecalis, okay? So fascium can cause endocarditis rarely, but fecalis still one of the common actually organism to cause infective endocarditis. Okay, so central line associated bloodstream infection, it's the most preventable hospital acquired infection, okay? So pathogen associated with what we call it CLABSI, central line associated bloodstream infection, are عندنا coag negative staphylococci, Staph aureus, Enterococcus faecalis, as well as non-albicans candida. Okay, and whenever you are suspecting bacteremia, don't forget to do 2 sets of peripheral blood, okay, and should be obtained from 2 different sites before starting the antibiotic. Okay. Okay, so mitigation, that's meaning we have risk factors, we can do something about them, okay? So they are not like gender or age, non-mitigated risk factor. No, mitigation, that's meaning we can actually do something to prevent this infection, okay? So for example, with the prolonged catheterization, every day you have to ask yourself, does this patient need this central line? Once there is no need for the central line should be removed, okay? Multiple central venous canalization, okay? Increasing the risk of central line associated bloodstream, okay? So basically try to minimize that. Multi-lumen central venous canalization, okay? Also use the minimum number of lumen. So minimum number of lumen as well as minimum number of lines, okay? Femoral line, given that it's close to the genitalia area, have higher risk. So usually we'll go for subclavian or of course internal jugular, okay? Usually we have to clean the sites very well before inserting the central line. Regarding TPI or TPN, your nutrition, if we can give it through the NG, probably it's better. And regarding the emergent insertion, يعني واحد crashing and you end up putting a central line in an emergency setting, so usually they're not going to يعني follow aseptic technique. So basically you will try to replace it as soon as possible. Okay, how about catheter-associated UTI? Well, it's the most common device-associated hospital-acquired infection. Up to 17 to 69% might be preventable, and this is based on a site. And some of the sites are trying their best to avoid that, and others are slacky and they're not doing a good job. So up to 50% can be preventable. E. coli is the most common organism. And when you have someone with catheter-associated asymptomatic bacteriuria, يعني بس عندهم bacteria in the urine without symptoms, it's basically they don't need treatment, okay? But of course, you should consider removing the catheter if they don't need it anymore, okay? So for the catheter-associated UTI, urine analysis and urine culture should always be obtained before starting the antibiotic. Remove the polycatheter whenever it's possible, okay? And then you start with a broad spectrum antibiotic, and then you can narrow the coverage as narrow as possible based on the culture results. Antibiotic usually being given for a total of 7 days, okay? Here a good point that there is some antiseptic coated catheter, يعني في a lot of advertising about those catheter يحطون مثلا زي مثلا antibiotic coating polycatheter. Unfortunately, those haven't shown to have any short-term nor a long-term benefit. They basically an expensive Foley catheter. Okay, so خلنا بس هذا. Regarding a surgical site infection, well, usually the surgical site infection will occur within 30 days after the surgery, or 90 days after the surgery if there is an implant, if during the surgery they implanted something. Okay. بعدين عندنا يعني categories for the wounds. الclean wounds which خلينا talk about a type of wounds وبعدين نرجع للسلايد هذا. Okay. So clean wounds meaning when they operate there was no sign of inflammation and basically there is no break in the aseptic operation theater technique. يعني شغل نظيف ما في شيء. They haven't even يعني touch any of the respiratory or GI symptoms. It's a clean surgery. نجي للنوع الثاني اللي يسمونه clean contamination. So those operations are involving a respiratory, GI, GU system. بس ما في significant spillage يعني بس هو عبارة عن إنه it's reaching that viscous. Okay. فهذه يسمونها clean contaminant. Okay. A third is basically a contaminated wound. معناته there was an acute inflammation مو بس يعني acute inflammation in the wound at the time of surgery. Okay. So this is called a contaminated wound. A dirty معناته في pus and there is a perforated hollow viscous. So هذا basically يسمونه dirty wound. And based on the wound type, we estimate the risk. So it can be less than 2% بالclean wound. يعني مثلا eye surgery مثلا comparing to 20% or even higher in the dirty wound. طيب. Again, we have some mitigation risk factors. You can see we can treat the hyperglycemia. We are trying to reduce immunosuppressive agents and those increase the risk of surgical wound infection. Cut the smoking, especially 1 month before. Trying to lose weight before any elective surgery. Avoid malnutrition. الناس اللي عندهم staph aureus خصوصا الناس اللي رايحين cardiovascular ولا orthopedic surgery, we may actually try to decolonize staph aureus. Skin preparation يعني كذا واحد shower before the night of surgery with soap and antiseptic. Removing hair, avoiding hypothermia, and of course incision dressing should be يعني closed and covered with a sterile dressing. Okay, this is just an example of pus coming out of a knee replacement surgery. And each type of surgery they will have a usual suspect, a common organism after the surgery. For example, in vascular, you will have staph epididymis or staph aureus. In orthopedic, also staph epididymis or staph aureus. In esophageogastric, you will have enterobacteriae or enterococci. In the biliary, you will have E. coli or enterococci. And this is really rely on what lives there, which organism usually are common flora over there. Okay? Okay. So time for question, guys. أسئلة يا شباب.